Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health System. Today, pharmacist Brad White and I are broadcasting from our administrative offices, and our guest is Dr. Marta Lavery and Aultman General Surgery. Good morning, doctor, and welcome to the show.
Good morning. Thanks for having me.
March is Colorectal Cancer Awareness Month, and it's dedicated to increasing screening rates, supporting patients, and promoting the prevention for the third leading cause of cancer-related deaths in the U.S. So we're going to spend the next hour discussing risks, screenings, and treatments. We'd like to remind you that our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe to our program.
So, good morning, Dr. Lavery. Tell us a little about yourself and your career as a surgeon.
So I'm originally from Cleveland, Ohio, and then I went to NeoMed in Rootstown for medical school. Then I went to Michigan State with Sparrow Hospital in Lansing, Michigan, where I completed my general surgery residency. And then we decided we should move even farther away, and I went to Seattle for my minimally invasive and colorectal fellowship at Swedish in Seattle. And then we were lucky enough to come back home, and now I've been at Aultman for the past 3 years.
Were you near Fort Lewis out there in Washington State?
No, I was near Seattle. We covered 3 different hospitals, but it was kind of within about the 40-minute radius.
Okay. What is a fellowship, and tell us about your fellowship?
So a fellowship is extra training. Most of them are either a year or two. Mine was only a year. And there I specifically focused on colorectal diseases and anal diseases. And I did a lot of surgeries on the robot. So I did most of my surgeries there on the robot, dealing with colon cancer, diverticulitis. I did a lot of hemorrhoids. And I also got proficient at colonoscopies.
So, how common is colorectal cancer?
Colorectal cancer is on the rise. It's about 40% of the population currently, and it's the second most common cause of cancer death overall.
So at what age should you begin colonoscopy screenings?
So it used to be 50, but with the rise of younger people having it, the screening guidelines changed a few years ago where everyone should start at 45 for average risk. That then becomes a little bit tricky when you take into consideration what is average risk. So anyone that doesn't have any risk factors, people who have a family history of a first degree relative with colorectal cancer. So first degree meaning your mom or dad, your sister, brother, or your own children, that's first degree. Or if you have a strong family history, for example, all your cousins on your mom's side had it. And then the recommendation is to start at 40 or depending on the age. So if your mom was diagnosed with colorectal cancer at 40, then you should start 10 years before. So you would start at 30.
So you kind of gave us some really good reasons about why you've lowered screening ages. Anything else you'd like to comment on based on what you're seeing in your practice?
It's the leading cause of cancer death in people under 50. Over the last 30 years, the incidence of people getting colorectal cancer under 50 has increased by 15%. I commonly see people all the time now who are in their 40s or late 30s with this. So it's important for people to get screened.
Do you think we're better at diagnosing now, and that's part of the reason why there might be more diagnoses, or is it because of our diets and lifestyle, or is it just everything all combined?
Probably everything all combined. Technology does improve as time goes on, and it does become more available to people as things move on. But I do also think environment and diet, lack of physical activity, all of those factors that we are seeing affecting other disease processes also plays a factor in this.
Okay. How often should you get a colonoscopy?
So that's also a tricky question because it just varies patient to patient. So all comers, if you don't have any risk factors, no family history, and when you get your colonoscopy, there's no polyps, then the recommendation is every 10 years. If you have polyps, then it just depends on how many you had, what the size of them were. And so then it can change to, having a colonoscopy next year, in 3 years, in 5 years. All of that varies. But if you have a family history, first degree relative with colorectal cancer, the recommendation is to always do it every 5 years, regardless. And then if something is found, then to do it much sooner.
So, doctor, what is the difference between a colonoscopy and a Cologuard?
So colonoscopy, you get light sedation, you're breathing on your own, and then a scope is inserted into the anus and the colon is evaluated in its entirety. Versus a Cologuard is a stool DNA test. So you submit a stool sample and it gets sent off to a lab and tested. And so this is supposed to be done every 3 years for average risk patients. I'd like to emphasize average risk because if you have a history of polyps or if you have a family history, you should not be doing this. There's also another test called the FIT test that detects hemoglobin, which is essentially blood in the stool. That should be performed yearly. And some of the guidelines suggest that every 5 years, patients should also get a flexible sigmoidoscope. So it's a short look up, it's not evaluating the whole colon. To be honest, I've never seen a patient have a scope done when they're doing this stool sampling test. I've only ever seen the stool sample test. So if you're doing that, then you're not necessarily following the guidelines.
Hmm. So, good question, I guess. Why do people avoid screening?
Well, the biggest complaint I hear from patients all the time is they don't want to do the bowel prep. And the bowel prep has changed a lot over the years. Patients, I think they think that they're going to be up all night, and that's not necessarily true. I mean, some patients might, everybody is different, but there's lots of other different bowel preps that are available now for patients to take. The one that I routinely use is called Suprep. So you guys both being pharmacists, insurances are actually covering it more and more now because I can see how much insurances will charge, and it used to be a lot more. And now for some patients, it's either free or $10. It's two little bottles, so they're about 8 ounces. And you drink one kind of in the night before, middle of the night, you mix it with water, and then you have to drink two more like big glasses of water, about 16 ounces each. And then you do it about 6 hours again before your procedure. And it does a pretty good job of cleaning patients out. It's cost effective, and you don't have to drink as much fluid as you used to. So I think
Do
that's
you,
one.
yeah.
I also think people have a fear of pain or discomfort from the procedure. Now, unless you request to not get sedation, then
Hmm.
you get sedated and you don't really know what's going on. You wake up from a pretty quick nap, and a lot of my patients are like, "It's over," and I'm like, "Yep, we're all done."
Hmm.
I think people also are afraid of the anesthesia itself. Some people are afraid of a positive result. And then there's also other barriers: insurance, transportation, not having a ride, family emergencies that come up, things like that, difficulty getting scheduled.
Do you perform colonoscopies?
I do. So I do them at the main hospital in Canton and Aultman. And I also perform them every other Friday in Alliance. And I'm fairly easy to get into. So if anyone wants one, I'd be more than happy to do it for them.
Okay. You talked a little bit about this in our opening, but can we talk more about who is considered high risk for colon cancer?
Sure. Patients who have a personal history of polyps. So if you have had polyps before, you've proven that you're a polyp maker. And so therefore you should continue with colonoscopies to catch whatever is made because polyps are what end up turning into cancer. We've mentioned first degree relatives, parents, siblings, children, or if you have one side that has at least 3 family members. If you have a history of IBD, so inflammatory bowel disease, such as ulcerative colitis or Crohn's, you are at higher risk. I actually just recently saw a patient who has a history of ulcerative colitis and has two colon masses that are both positive for cancer.
Mhm.
History of cystic fibrosis. There's also a couple of hereditary cancer syndromes. African American and American Indian populations are also at higher risk. And then there's also lifestyle, such
Hmm.
as obesity and diabetes, long term smoking. So, patients who are long term smokers routinely are at higher risk of getting polyps. And the more polyps you have, the higher chance of having cancer. And then overuse of alcohol can also contribute to the rise in
Hmm.
colon cancer.
Hmm. Okay, so can you tell us what a polyp is?
So, a polyp is just an abnormal growth of the mucosa being the inner lining of the colon wall. The colon wall has 4 layers. And about 40% of people by the age of 60 will have a polyp. A polyp is a benign finding. It's something that, meaning non-cancerous, it's something that needs to be taken care of because left unchecked, it will turn into cancer, but it's not anything that people should be worried about.
Okay. It's, I guess it's, you hear polyp and you think, oh my gosh, this is bad. I mean, polyps probably aren't good. Is there a cause for polyps? Is it like, is that something that's like straining at the stool, or is it just dietary, or is it just genetic, or is it a little bit of anything?
Straining doesn't cause polyps, but it's all kind of a little bit of everything. So environmental factors, things that we do to our own bodies with the smoking, alcohol use, the food that we consume, and then there is a role for genetics in this as well. So it's kind of a little bit of both because there are people that I know who you look at them and they're the healthiest people ever. They don't smoke, they don't really drink, they eat healthy, and they still get it. So unfortunately, sometimes it's just bad luck.
Okay. Okay. So how about this? When should a patient stop getting a colonoscopy?
So the guidelines will tell you 75 when you're 75 or 80 years old. I tend to tell my patients differently just because if you have made polyps your whole life, your body doesn't just decide that, oh, I'm now 80 years old. I'm not going to make polyps anymore. That doesn't happen. You're going to continue to make them. And so, left unchecked,
Hmm.
I see a lot of patients then who are in their 90s come back with pretty big colon masses and colon cancer because they either never had a colonoscopy or they stopped doing it 15, 20 years ago. So I always tell my patients, if you're healthy enough and you and your primary care doctor are agreeable and your heart's okay and you think it would be a good idea and you can handle the anesthesia, then I would continue to do it because the burden of the anesthesia is much less for colonoscopy than for doing a major colon surgery. And the
Hmm.
recovery after a colonoscopy is easy. You just wake up and you can't drive that
Hmm.
day because you got anesthesia, but there's nothing special you have to do afterwards versus the recovery after colon surgery is much more involved.
Hmm. Okay, doctor, it's time for our first health break. You are listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Are you ready for vaccine season? Stop in or schedule your pneumonia, Tdap, or shingles vaccine online at medshoprx.com. Doctor, is there a role for genetic testing?
There is some. All of the specimens that are removed, meaning whatever polyps or biopsies are removed on colonoscopy or colon tissue that's removed during surgery, it's all sent for genetic testing for four genes, the MLH1, MSH2, MSH6, and PSM2. And this helps maximize identifying patients with Lynch syndrome, as those patients have a lifetime cancer risk of 15 to 20%. And then another one that is something that people learn about in textbooks or might have heard of is called FAP, familial adenopolyposis. It's basically a polyp syndrome where your colon is full of hundreds upon hundreds of polyps. It's impressive to see in pictures and in real life. And so those patients, if you have more than 20 polyps at a time, it's recommended to test for that because that has a 100% risk of cancer. Or if
Hmm.
you have a family history of that polyposis syndrome, then you should also be tested for that as well.
Is colorectal cancer on the rise?
Yes. So those born in the 1990s are much higher risk, at least five times higher than those born in the 1960s, which is crazy to
Geez.
think
Wow.
my generation versus my parents' generation, I'm at a much higher risk than my parents are of developing in my lifetime.
Hmm.
Wow. Well, what's the relation there? Do we know?
If I had to guess, I would say similar to the risk factors we've talked about, if you think about how our diet has changed over the last 30,
Hmm.
40 years,
Hmm.
physical activity, things like that, eventually that catches up.
How do you stage colorectal cancer? Colorectal cancer.
So colorectal cancer is staged, it's a multi-step process. So first we obtain CT scans if we know the patient has colon cancer to determine whether or not the patient has spread to other organs, meaning stage four metastatic disease. And so if it's spread to the lungs or liver, which is typically the most common locations for metastatic disease, then surgery isn't always necessarily offered. Surgery is for a cure. And so if patient has metastatic disease, oftentimes a cure is not able to be achieved at that point. There are extenuating circumstances where combo colon liver resection, depending on size of the liver metastasis and how many can be performed. But
Hmm.
typically, if patients have metastatic disease, then the most we could really offer them is diversion because then the risks outweigh the benefits of doing surgery. So once we obtain CT scans and see that those are clear, We perform surgery, and then the pathology is really what helps us determine staging. Patients always ask me about staging in their preoperative visit, but it's really hard for me to tell them because I don't know if there's any lymph node involvement. Lymph nodes are typically not seen. If they're involved, they're typically not seen on the CT scan unless they're really, really big, and that does not happen very often. And so when I do the colon resection, you have to remove a big piece of tissue. Patients always think that I'm going to take a very small portion out, but you end up losing at times 8 to 12 inches, which is a huge chunk, but most patients have 5 to 6 feet. And the reason they do that is because you have to go based off of the blood supply. The colon blood supply is not as forgiving as the small intestine as far as providing good blood flow for things to heal. But the lymph nodes also live along the blood vessels. And so, per the guidelines, I have to take out at least 12 lymph nodes to say that I did an accurate sample size. They usually always get more than that. And so then the pathology takes a while. It can take 5 to 7 business days to evaluate everything because you have to cut up the specimen and you have to see how many layers of the colon wall are involved. So that's the T portion. And so, T1, 2, 3, 4. Then you evaluate the lymph nodes. And so if there's any lymph node involvement, that changes the N portion. And then obviously patients are more than likely M0, the metastatic portion. And so patients who have any lymph node involvement, chemotherapy is recommended. And then it also depends if there's no lymph node involvement, the tumor size, the higher up ones, sometimes chemotherapy is recommended by our medical oncologist. So it can be a little complicated. It's not as straightforward. There's lots of things that go into that. And we need to obtain imaging and do surgery first before we can give patients the full picture as far as staging goes.
Wow.
So is there a difference in treatment of colon cancer versus rectal cancer?
Yes. Colon cancer is much more straightforward. The first line of treatment is surgery. And then, like I previously mentioned, if there's lymph node involvement or depending on the tumor size, then chemotherapy is recommended. There is no role for radiation in colon cancer. As far as rectal cancer, it gets a little bit more complicated. We've talked about advances in technology. And so in the colorectal world, we really try to preserve patients' rectum. The rectum is a storage unit and it plays a big role in function. So any portion of your rectum that you lose that storage capacity, and you can end up with frequency of bowel movements, meaning having to go more often, having accidents, having diarrhea. So we try to, protect that. And so upper rectal masses, a lot of times surgery is still done first, and then depending on the pathology, you can consider chemotherapy. Radiation, if it's done, is typically done before surgery. Radiation's purpose is to shrink the tumor and help try to prevent spread, as well as chemotherapy's job is to help prevent spread. Now, if patients have a lower rectal tumor, meaning that it's pretty close to the anus, then we do total neoadjuvant therapy. What that means is we do chemotherapy and radiation first in the hope to try to shrink everything and have everything go away, because the alternative for surgery is to remove the entire rectum and anus, and then patients end up with a permanent colostomy bag. So there's new literature out now that suggests you can do chemotherapy and radiation first, and I have had some patients with success. They have to do closer monitoring and surveillance, but I have had some patients with complete response. And so they have cancer, but they're able to avoid any kind of surgery because they have a good response to chemotherapy and radiation. So rectal cancer is a little bit more trickier and complicated and takes a little bit longer to explain to patients.
Wow. All right. So I know you've talked about it a little bit, but maybe we ought to just refresh the listener's memory about symptoms and things. So if someone is having, like, for example, rectal bleeding, I'm assuming, they might see blood in the stool or blood in the commode. What should they be concerned about?
They should be concerned about the bleeding. No, bleeding is not normal. I see patients all the time that just blame things on hemorrhoids, but the bleeding persists and then they have other associated symptoms. And so you should never ignore bleeding. You should always get a colonoscopy to evaluate it. If you've just had one recently, then sure, it probably isn't going to be a tumor. But the number one thing that I see is patients blame bleeding on hemorrhoids, and then I see them and I have to tell them the bad news that it's not. Other symptoms that you might see is change in bowel habits. So patients will have diarrhea that's new for months, or suddenly they have a harder time going to the bathroom and they have constipation, and then they develop bloating because they're having a hard time going to the bathroom, abdominal pain. I've had some patients complain that they notice more mucus. So anytime you have anything that's new, any change, unexpected weight loss, anemia that can't be explained, All of that should kind of perk your ears up that something is not right, and you should seek a colonoscopy to
Mm.
make sure and see what is going on.
Okay. What any other symptoms that should just absolutely not be ignored?
Weight loss, anemia, rectal bleeding, change in bowel habits, all of those
Okay.
things, especially if you have a family history that you know of.
Okay.
Are there modifiable risk factors?
Yes. So decreasing red or processed meat. I've been seeing all over social media and the internet now about processed meats being classified as a class 1 carcinogen. So processed meats that can increase your risk of developing polyps, ultra processed foods, so the fast food, things that are more in the middle aisles of the grocery store. I kind of always try to stick to the outside of the grocery store where there's like the fresher, real food. Decreasing obesity. Obesity in itself is just an inflammatory condition that can increase colon cancer. Increasing physical activity, becoming more active, again, that will decrease obesity rates and help out with chronic inflammation. And then also changes to our gut microbiome. It's not something that we all think about, but our diets, our exposure to antibiotics, exposure to being obese, processed food, overconsumption of sugar, all of those things cause chronic inflammation and can wreak havoc on our body.
What is surveillance like after treatment?
So surveillance is everyone is recommended to get a colonoscopy 1 year after the diagnosis, and then every 3 years, and then for 3 years, and then 5 years. But that's if nothing else is found. So if you have a clear colonoscopy, that's what you should do. But if you have a polyp, then you need to be screened much sooner. And then as far as so for stage 1, all you need is a colonoscopy right afterwards. As far as the other stages of colon cancer, you see your physician, so it can either be me or the medical oncologist, and we order a lab value called a CEE, which is a tumor marker, and that's done every 3 to 6 months for 2 years, then every 6 months for 3 years. And then we do a CT scan of the chest, abdomen, and pelvis to check for any signs of regrowth or new things that are concerning, and that's done every 6 to 12 months for 5 years. So the surveillance period is 5 years from the time of diagnosis and treatment. And then after that, patients are still considered a little bit higher risk, but they're kind of outside the window of a reoccurrence.
Okay, doctor, it's the bottom of the hour. Time for the news. Thanks for joining us this morning and on Health Matters with the Medicine Center Pharmacy. Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning we are talking with Dr. Lavery, and I'm sorry for the delay. Uh, um, how how has minimally invasive surgery improved recovery?
Oh, huge. Patients who had surgery in the 90s or before that, they had a tube in their nose called an NG tube to drain the stomach contents for several days after surgery. Patients were essentially not given anything to eat for several days after surgery. Patients spent a week or longer in the hospital, which that in itself can cause other problems. Patients can develop blood clots from not moving around. But now there's so many things that we do differently. I use the robot for most of my colon surgeries, and so the incisions are much smaller. Most of the incisions are about this big, and then there's another one that's about this big, about 4 centimeters, that I do because I need a incision to remove the specimen from. But the incisions are so much smaller, and that helps with pain control. There's also the enhanced recovery protocol that we use in the colorectal world, and so that really does kind of help facilitate people passing gas and having bowel movements and returning back to their life sooner. So what that means is all of my patients will get a block, meaning anesthesia will numb up the abdominal wall muscles. And so that usually lasts for about a day or two. And that really helps with pain control. So patients are up and moving much faster because it doesn't hurt as more. So you're having better pain control, smaller incisions, which don't hurt as much. All of my patients are shocked when I tell them they can eat the day of surgery afterwards, of course, but they all get a regular diet after surgery. I expect them all to get up out of bed the day of surgery and start moving around. And my patients all go home about day 1, day 2 after surgery. As patients are shocked because they think that they just have to stay, but people do better at home. You know, the food's always better. You're used to, your own bed. Nobody really wants to kind of just lay around in a hospital bed for, days at a time. And so my criteria for going home is eating, urinating, walking, and pain's controlled because they will go home with pills. They won't get the IV stuff obviously at home. And then passing gas and having bowel movements, that usually happens day 2 or 3. So I always tell patients I don't necessarily wait for that to happen because that will just kind of naturally happen on its own. But robotic surgery has been huge. The visualization, I can see things so much better. I can get the camera to go so much lower in the pelvis. It can kind of reach around into smaller portions.
Mm.
And with the
Hmm.
robot, it basically is like I'm using my own hands because I have wrist motion with the robot tool. And so it's basically as if I was doing this open without having this massive open incision. And so it's better for me as a surgeon, it's better for the patients. There's a special dye we can give at the time of surgery that can help me check blood flow, which I always do. So when I'm doing surgery and I'm putting things back together, I'm able to see which part of the colon has good blood flow. And that way I feel another tool where I can feel pretty confident that the surgery I've done, the patient will have a good outcome because at least our blood flow is intact. So it's just been huge. And there's so many different things that we can do now versus before having the robot or stapling
Mm.
techniques. A lot of patients probably did end up with a colostomy just because it was way too hard to reach down low to be able to put these
Mm.
people back together. So quality of life is just so much better for the patients.
Well, those robots are really busy, aren't they? Down there.
Yes.
My gosh, every physician we've interviewed on the on this show is way ahead of things with the robots. So, how many robots are down there? A dozen?
We have 5 in the system. So we have
Oh.
3 at the main hospital. We have 1 in Alliance and we have 1 in Orville. But the robot technology is huge. It's helped for so many different things. I know our urologists and our OB/GYN colleagues use them
Mm.
as well. I think our cardiothoracic surgeons use them for lung surgeries.
Mm.
We do gallbladders, hiatal hernia repairs. So when the stomach
Mm.
contents are going up into the chest. Also, all different types of hernias. So hernias in the groin, on the
Mm.
belly. My partners and I, we use them
Hmm.
pretty frequently. So some days it can be really hard to just
Mm.
randomly add a case on last minute
Mm.
because it's been used.
When I
Wow.
when I first saw one at the Angel auction, I thought it was something out of a spaceship. I did not. They didn't explain right away that it was a that it was a robot for surgery.
It can
Yeah.
make patients a little nervous. Some
Yeah.
of the older generation, they're a little nervous and apprehensive because they're like, well, is the robot doing it? And I'm like, no, the robot does not move unless I move my hands, but it's a great tool to
Hmm.
have to be able to do surgery.
Jeez,
Hmm.
that's very interesting.
So, what determines whether a patient gets a colonostomy
A
or
colostomy.
a colostomy? Excuse me. Yes.
So I'm glad you asked that because I have so many patients who come in and they do their own research. And I think we talked about previously why patients maybe don't want surgery or don't even want to address the problem. And I think it's because everyone's so deathly afraid of having a colostomy. But the colostomy is not my goal. So it's pretty rare if you come in electively for surgery. If you come into the hospital and you're having, difficulty having a bowel movement, bleeding, bowel's not prepped, we didn't do a bowel prep, then the colostomy is much higher when you come in through the hospital. But in the elective setting, when you come into my office and we discuss what's going on, I don't plan on giving patients colostomy. Yes, that's kind of my backup if things don't go
Mm.
very well or I'm having a hard time getting things to reach. But on the right side, which is usually what patients are always afraid of, but on the right side, it almost never happens because right-sided colon cancer, you're connecting colon to small intestine, and small intestine has great blood flow and is very forgiving. And so on that side, you hardly ever have to give a patient an ostomy. And then on the left side, usually we're able to get things back together. We're able to kind of mobilize or detach things as needed to pull things down where we need to get a connection. And so I usually work really hard to try to get people back together. There are those chances where sometimes they don't, but for the most part, it's pretty rare. So, but yes, it can happen. And I think that also contributes to the fear that patients have because patients will tell me that they'd rather die than have that. And so then I think sometimes they just avoid getting evaluated and getting treatment because they just don't want that option to even be discussed.
Mm.
All right. So, that comment kind of leads me into what we hear in the pharmacies, which I wanted to see if you could maybe just allay some fears, if you will. And, can you talk about some big misconceptions that you hear patients have about colonoscopies and the fear of getting them? because I can't tell you, I'm sure you know, but I can't tell you how many people we've encouraged to stop avoiding the phone call to schedule their appointment, because it's better to get your screening and find out what's going on right now than to put it off and find out in a year. It's not fixable.
Hmm.
I think some of it is the bowel prep. Unfortunately, people are just so afraid of that. It's really not that bad from talking to the patients that have done it, especially with the soup prep nowadays. There's not as much volume that you have to drink, and you're not. So there are some patients, depending on what prior history you have with constipation and things like that, who are up all night. But most patients aren't up all night. You do the bowel prep, you go to bed, you wake up once or twice in the middle of the night, you go, and then you have more liquid come out the morning of. But the bowel prep is really not that bad. I think some of it too is patients kind of know something's wrong, but it's that whole mental game of I just don't want to address it because I know something is wrong, and what's wrong is probably really bad. The patients who have had bleeding for months or years, and they're like, oh, it's just a hemorrhoid. I've always had this. Or all of a sudden, I'm having difficulty having a bowel movement, or I'm now going all the time and it's liquidy. And so you kind of know intuitively. I think everyone kind of knows that something's wrong, but sometimes it's hard for people to address that. I myself personally, I think part of it just because this is what I do all the time, I'm very aggressive in my own care where it's like, if this is happening, I know I need to solve this because I know what the alternative is, and let's get ahead of it so we can fix it now versus waiting down the road. Well, now there's nothing that we can really do. And patients get frustrated with me, but I'm a little frustrated too for them because it's like you've had this for so long and you took so long to get evaluated. Now it's to the point where
Hmm.
like I really can't help you. And maybe a few months
Wow.
ago I could have if we had addressed this. And so I
Hmm.
get frustrated for them too.
Hmm.
It's time for our final break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. Thank you for joining us. Let's get back to the last segment of the show.
Doctor, can you recommend any lifestyle changes to reduce colon cancer risk?
Decreasing obesity is a huge one. Obesity causes chronic inflammation and can cause all kinds of different problems and medical conditions. Better control of diabetes and blood sugar control, decreasing overconsumption of sugar, processed foods, processed meats. It's unfortunate. My husband and I were actually talking about this today. It's so hard to try and figure out what to eat for breakfast because the American breakfast is bacon, ham, all the processed meats that we think about. And then lunch is usually lunch meat, bologna, turkey, ham, all those things, pepperoni, but really trying to decrease the consumption of those things as it's been shown to increase your risk of colon cancer. Increasing physical activity, smoking can increase colon cancer risks, overconsumption of alcohol. So all those things are modifiable risk factors. Increasing your fiber, so either dietary fiber or a fiber supplement such as Metamucil or fiber that also has been shown to help decrease the risk.
Fiber is I continue to have challenges in getting enough fiber per day. So I feel like I eat pretty well and I exercise well, but man, sometimes fiber's hard. And I know that sounds kind of dumb, but I'm sure I'm not the only person that struggles with it. So, you know.
Fiber's hard. I have my patients who tell me they think that they're eating a lot of fiber. When I ask them what they're eating, they really aren't eating as much as they think. Lettuce, salads, those types of things don't necessarily have as much fiber as people think. I always tell people to read food labels. But avocado, raspberries, chia seeds, those types of things are pretty high quality fiber, and you really need more than you think. The recommendation for women is about 25 to 30 grams, and for men is actually 37.
Wow. Now you're really making me feel bad. Okay.
Hmm.
So I was reading a Twitter post this morning about different things with fiber, and I had looked at some chia seeds at the grocery, and my wife made fun of me a little bit. But I'm like, between black beans and lentils and chia seeds and broccoli, I mean, how much broccoli can you really eat a day,
Chia seeds
But
are good. Chia seeds are for I think 2 tablespoons, you get like 10 grams. So if you need
yeah,
30 grams a day, it's a third of the way there.
yeah.
Hmm.
So very interesting. Any other? So let's see. We've only got a couple minutes here, but I want to make sure. Give us your take on your Aultman team and why patients should consider choosing you and your team to make sure they take care of their colon health.
Aultman just feels like home. A lot of the patients don't necessarily want to drive far to go to other hospitals up north because, again, they have transportation issues and they really just want to stay home, make it easier for their families to visit them. Our team is lovely. I love everybody on my team in the office, my nurse practitioners, people I work with in the operating room, the nurses on the floor. If you have a concern, everyone's willing to help you out. Everyone is just so kind and so nice to all of our patients. I think we have great technologies. We've talked about previously. We have 3 robots at the main hospital that we utilize to get better patient outcomes. We have a brand new cancer center. So our medical oncology team, the chemotherapy doctors essentially, and our radiation oncology team are located there. So patients are able to get all of their care at one location. And then as far as me, I am very easy to talk to. My door is always open and I have a pretty good turnaround. So from the time a patient sees me in the office, I can usually get their surgery scheduled within 2 or 3 weeks. I had a patient one time, I saw her on Friday and I had her scheduled for Monday. So I'm really willing to work with patients. I take all of my cancer patient cases very seriously, and my scheduler and I work closely together. So if a patient has to wait longer, I always tell her that's not good enough and we have to figure things out. So whether that's moving things around my schedule or trying to figure out where we can find, free time in the operating room, that's what we do to try and take care of patients, because patients, as soon as they get that cancer diagnosis, they want it done today. And so we work really hard to try and get people taken care of quickly.
So, question for you, and probably from the listeners too. So, you mentioned some of the high risk things you should be looking for symptom wise, like weight loss and unexplained diarrhea and blood in the stool, to name a few. If you experience that, what should a patient do? Should they call your team directly? Should they call their primary care first? What's the chain of command to get someone care quickly?
Most of my patients can just schedule directly. I think some insurance companies require referral, and off the top of my head, I don't know that, but um, they can either call my office and try and be scheduled as soon as possible, or reach out to their primary care doctor. And the primary care doctors, they all kind of know how to reach me to say, hey, I have this patient I need you to see urgently. And we're really good about squeezing people in. The cancer stuff, I'm very good about getting people in as quickly as possible and kind of double booking a time or things like that to get people seen quicker.
I want to give a plug to in the pharmacy. We often hear people come in that don't have a primary care doctor. So it's very important that you have a primary care doctor that knows you and your situation. So I'm quite sure Aultman has resources for you if you don't have a primary care doctor, and you can call them or reach out on their website and they can help direct you to providers that are taking patients. But anything else you'd like to summarize for our listeners today to give them a good overview of how important colorectal screening is and Colon Cancer Awareness Month is?
Never ignore bleeding. It might be something that is just hemorrhoids, but it could be something worse. Don't ignore changes in bowel habits. If you have a known family history, please get evaluated. And a colonoscopy is not as bad as you might think. I actually have lots of patients that say afterwards, this actually wasn't that bad, or, oh, we're done. And I promise a colonoscopy is a much easier, swifter recovery than having to undergo a major operation that in itself can have complications or other things that can happen just from being down and having to be in the hospital for a certain amount of time. So I can't emphasize enough how important and how passionate I am about this. And if you have any questions or have trouble being seen, I'm very available. If people want to talk about colonoscopy and what that entails, I'm more than happy to talk about them with them in my office. If they're not sure if they need one, we can talk about that. So I'm always available as a resource. People don't always necessarily have to go to their primary care doctors. They can always come to my office and we can talk about it as well.
Okay. Thank you to our guest, Dr. Lavery. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health System and our listeners joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you again right here next Friday on News Talk 1480 WHBC.